Good evening, ladies and gentlemen. Today we are in the second session of special lecture of as part of the 3PE, the Public Policy and Program Evaluation Workshop conducted in collaboration with Cornell University and Gram. I'm very privileged to tell you that we have a distinguished guest today who's going to deliver a special lecture on the expertise of handling large-scale healthcare projects and how the monitoring is done. What challenges do they face? All these kind of nuances they're going to tell us about during today's session. Let me take this opportunity to welcome Dr. Ravi Kumar AV, the Deputy Chief of Party for NISHTHA USA. He holds MSc Masters in Public Health. I would like to welcome you for this session, Dr. Ravi Kumar. At the outset, I would also like to welcome the chair of this session, Dr. Arun Kapoor, our beloved professor and who has been teaching us quantitative techniques. Welcome to the session, sir. Also, I'd like to welcome my colleague, Dr. Ananya Samajda, Deputy Director, Gram Research. I would like to welcome for this session, Dr. Ananya Samajda. On this auspicious occasion, we thought we would also like to, release some of our fact sheets, what we have developed in the areas of health. I would like to I would also like to welcome all of you for this session at the outset. And also there are more than 200 people who are enrolled for this online session. There are people joining online. I also welcome all of you for this session. I would like to hand over this session to Dr. Ananya for the release of our fact sheets. Over to Ananya.
Thank you so much. After a warm welcome to Dr. Ravi Kumar, I think we should proceed to one of the early items of today's session. So, the reduction of out-of-pocket expenditures is a core priority with respect to universal health coverage, as we all are aware. So, I'm happy to share that Gram has conducted a comprehensive study of out-of-pocket expenditures which are incurred by below poverty line women in seeking maternal care in public health facilities. So we did this study for the Karnataka Evaluation Authority. We studied over 2,000 below poverty line women and their families to find out what are the reasons for incurring out-of-pocket expenditures, what is the level of out-of-pocket expenditure, what are the components of it, what are the sources through which out-of-pocket expenditures is being met. So again, I'm fortunate to share that today is the occasion when we shall have the release of the fact sheets prepared out of this study. As you know, that the evaluation reports are often large. So a fact sheet is a way in which we can present the findings of an evaluation report in a simplified, abridged, and appealing visualized form. So with the effort of the communications team, Ms. Akshita here, her team especially, and of course the research inputs provided by the research team of Gram, these two fact sheets for the out-of-pocket expenditure study have been prepared, which will be released today. One fact sheet is on the components and the reasons of out-of-pocket expenditure and the sources, and the other one is mainly on the causes of out-of-pocket expenditure, relating it mainly to the state of infrastructure in the public healthcare facilities. So without further ado, I would like to request Dr. Ravi Kumar to do us the honor of releasing the fact sheets.
I request the Executive Director of Gram, Dr. Ravi to join us.
volume 1 of the parts.
Thank you. We expect that these fact sheets will be useful and interesting for all those who are working to make a difference in the sphere of public health, so whether it is the decision makers in government, researchers, and everybody else. So now I would like to invite Dr. Ravi Kumar to deliver a special session for today, which is on monitoring and evaluation of large-scale development projects, the importance, the issues, and the challenges, especially in the sphere of public health. Over to you. How would you like to speak?
Yeah.
And computer system.
Okay.
Yeah, you might have to do it through your.
Is there any chance you shift the keyboard to pen?
Yeah.
Ask the mic. Let's see. This is here. This section. Yes. Okay.
Good evening, everyone. I am Ravi. I work with NISHTHA-Jhpiego NISHTHA as Deputy Chief of Party for the project NISHTHA. NISHTHA is USAID's flagship health systems funding project. We are working with state and national governments for improving the comprehensive primary health care across 12 states of India, especially the EAG states and the northeastern states. I had structured my presentation to give a brief idea about what is program monitoring and evaluation, but after I received the candidates profiles, then I felt I am very junior to all of you, and then I can't speak. I'm not qualified to speak what is monitoring and evaluation. So I'll just skip through the slides which I had referred from existing resource materials. And then I'll briefly take you through the what is CPHC, Comprehensive Primary Health Care, why did it came into picture, and what is it intended to do. Because I felt a brief understanding of CPHC is required to sort of briefly discuss what we have done under the MND framework for the CPHC work we are doing, and then we'll briefly discuss the challenges we faced, and then I'll be open to learn from you all based on your experience and expertise. Briefly, what is program evaluation? Program is something, any set of organized activities supported by a set of resources to achieve specific and intended result. And this is what the dictionary defines. And when it comes to program evaluation, this systemic collection of information about the activities, characteristics, and outcomes of programs I would say the studies have again, time and again indicated that more than 80% of the healthcare needs can be addressed by the robust primary healthcare system. If you have the comprehensive primary healthcare system, if I have to take the example of a period of 1 year, then over the period of 1 year, more than 80% of the needs, for more than 80% of the times, I need not go to a secondary and tertiary hospital, which is away from home, which requires time, which requires resources to travel to that place. And most of the times, these hospitals are crowded, and most of the times, I would incur lots of out-of-pocket expenditure when I visit the facilities. So, it is necessitated that the pyramid of the base should be strong, should be comprehensive, and should be available closer to home. And we all know we consider Bhore Committee report as the Bible, Gita, and Quran in the public health, and then that was the point where it was reiterated that vertical programs are okay for shorter period of time, but when it comes to achieving the overall health, we need to have integrated care where there are provisions for the forward and backward linkages, and the community ownership is strongly present, and also the primary healthcare should be is comprehensive. So, keeping these things in mind, there was a situational analysis conducted by the Government of India around 2014-15 by the public health experts, and they identified that there were a triad of problems, especially in the area of primary health care. The primary health care that was available at that time was very selective. The primary health care, I mean to say the care that is available at the sub-center and at the primary health centers. The selective, I mean to say there are only a few RMNCHS services that are being provided, ANC, immunization, a few infectious disease services like sample collection for malaria or TB. But if you look at the requirement of the community, it's not just the RMNC, it's much beyond the RMNCHA. And in the past few decades, we have been witnessing the demographic transition and epidemiological transition. Like if you might have heard maybe 2 decades back, the NCDs, the hypertension and diabetes were called the disease of rich. But if you go today to any village, any community, there will be 1 or 2 person in each family who are suffering from diabetes or hypertension. And these studies have indicated, the disease burden study, which is famously called, more than 50% of the deaths in India are happening due to NCDs. So the India, which was traditional to infectious diseases, maternal and child mortality, is currently facing a double burden of the infectious diseases, which are very traditional to our country, and also the NCDs because of the epidemiological transition. And also because of these interrelated factors, the healthcare facilities, the primary healthcare facilities, the utilization percentage was very low. It was close to 28%. Only 28% of people had ever used any primary healthcare facility, though that was there closer to them home. And only 21% of the population had used any primary healthcare facilities. These three interrelated factors, and also as I mentioned, there are few health indicators which are still unfinished. I would say unfinished agenda for our country. Like still the TFR, there are few states and few districts which are still above the population stabilization rate, and IMR and MMR, we are one of the, in terms of IMR ranking in the IMR MMR, we are one of the lowest ranking countries in the world. And nutritional status, when it comes to especially the children and the pregnant women, the women of reproductive age, anemia is, if you look at the NFHS4 and NFHS data, it has increased in the past 4-5 years. So the traditional diseases we have not been able to control, and more and above that, we have received the burden of NCDs. So keeping these things in mind, the task force which was constituted in 2014-15, they suggested complete revamp of the healthcare infrastructure so that we are on the right road to achieve the universal health coverage. the base of the pyramid, complete revamp to make it comprehensive, not just the RMNCH and few national health programs, disease control programs, but also the NCD, mental health, geriatric health, oral health or palliative care, and with focus on the health promotion, disease prevention and health education. Because primary healthcare is all about disease prevention and health promotion. So keeping these things in mind, it was suggested that the primary healthcare facilities are completely revamped to provide the comprehensive care, and there should be a mechanism for seamless forward and backward linkages between the secondary, tertiary, and primary healthcare facilities. And if you look at the out-of-pocket expenditure, most of the times the out-of-pocket expenditure is happening at the level of secondary and tertiary care. So there should be a provision for protection of population against the financial catastrophe due to health adverse events. So keeping these things in mind, the primary healthcare facilities were revamped as health and wellness centers, and there was a provision of PMJY, Pradhan Mantri Jan Arogya Yojana, where eligible families were given a package of coverage of 5 lakh per year. It is expected that once implemented as per the plan, the universal health coverage, which lies on the principles of equity, financial protection, and the quality care, should be a reality. Briefly about health and wellness centers, key features of health and wellness centers are expanded range of services, the very limited range of services which are being earlier provided at the health facilities, RMNCH and national programs, are being expanded to include ENT, oral health, mental health, basic emergency services, geriatric and palliative care, and the health promotion and wellness activities are being given a lot of focus. Reaching the last mile, each and every health and wellness centers, with the essence is within the 30 minutes of any mode of travel, I should be able to receive the primary care. So the sub-centers which are expected to be catering 5,000 population are being converted to health and wellness centers. And one of the important component of the sub-center health and wellness centers, I would say, is the ensuring mandatory available of community health officer. A community health officer is a GNM or a BSc nursing graduate or a Ayurveda graduate who would be trained in public health and primary health care functions, primary health care skills, and they are made to function at the level of sub-center. That is, as per current norms, each and every panchayat has one sub-center, and each sub-center, if they get this additional HR, human resource, we expect primary health care should be very strong and comprehensive. NISHTHA, as I mentioned, we are working across 12 states. Our focus area is on through primary health care. Our focus area was on RCH, MCH, family planning and TB population. With the emergence of COVID, we expanded our area of work to include COVID response also, and we expect the sustained healthy behaviors, especially the wash behaviors, are basic to prevent any infectious diseases. So we have partnered with the state and national government so that the interventions are designed around these key areas. So this is our portfolio. As we stand today, we are present across 12 states, 14 states, working across COVID, CPHC, oxygen ecosystem, and healthy aging behaviors, and also strengthening surveillance component. I'll not get into details of what interventions we are doing. We refer to the PHC Performance Initiative Framework, which has been recently released, which guides the PHC activities on designing the interventions and designing the plan and what level of activities should be planned. So this has been our basis for for developing our key interventions at the national and the state level and district level. As we all understand, the first step for developing a robust monitoring and evaluation framework is the theory of change, the logical framework. So based on that PHCPI framework, Primary Healthcare Performance Initiative framework, we did design our theory of change, keeping the similar principles in mind, and our outcomes and the impact are mainly related to the MCH, FP, and TB population. So, for all the projects which we are working across the 12 intervention states, CPHC, WASH, the surveillance, and the COVID areas, we in close coordination with the state ownership, state governments, we have developed this key set of indicators. If you look at the CPHC program, our monitoring and evaluation framework, the key indicator that we are following is the number of. The first and foremost is the number of health and wellness centers that are being operationalized across the intervention states, and another component of the CPHC is the certificate course, where through a 6 months program, the nursing or the Ayurveda graduates are being given a training of 6 months to enable them as the CHOs, and this becomes our another key indicator. What I'm trying to say is that we have a certain set of key outcomes, outcomes which we are expected to produce to the Government of India or as per the CPHC mandate, and our MND framework, we have tried to align to that key outcomes which Government of India is expecting, or which the state governments are expecting, and we have developed our key indicators as per the mandate of the country and the state. So while that the mandate, CPHC mandate guides us what to do and what not to do, the data sources which we are using across these interventions, there are two set of data sources: the program data, which is mainly owned by the system, the Government of India and the state governments. We work with them to understand what is the progress across the key CPHC areas. The first example is the SWC portal. Each and every health and wellness centers are mandated to report their service statistics through a web portal, and using that portal, we try and analyze the progress. We try and analyze the footfall, the availability of medicines, the dispersal of diagnostics and other key service statistics, and we work with the state MND cell and the national MND cell closely to try and improve the indicators that has been mandated in the CPHC operational guidelines. NCD portal data, it's a beautifully designed system where each and every NCD patient that is being screened right from the community to the higher facility is being entered, and then the primary healthcare team, the ANM, multipurpose worker, and CHO are able to track whether the patient is on right treatment and whether the patient is undergoing the regular follow-up and checkups or not. The other platforms which we are using is the HMIS data. While we're working closely with the state MND cells, we try and understand what has been the progress. There are multiple studies and analysis that has happened on the quality and validity of HMIS data, but by the end of the day, that is the data that is available for everyone in the healthcare system, and we do work with that available data without duplicating or without reinventing the another system. The learning labs are key interventions for NISHTHA, where we are trying to address the long-standing public health issues with a innovative models or a demonstration models, and each and every learning lab, for example, we have few learning labs in the social accountability area, and another learning lab in the TB family care, and another learning lab in the midwifery care, strengthening midwifery care. So we do have our own system in these areas, in these learning labs, and this source of data guides us in our routine monitoring and evaluation program. Along with this, we use our HR, the staff, field staff, to sort of produce program management data. Like one of the system we have developed is the supportive supervision visits to the health and wellness centers and the study centers where the CHOs are being produced. CHOs are undergoing the IGNU course, and then so our HR, our staff, our team members, they regularly visit these facilities, and we have a structured checklist which try to elicit the quality parameters, whether all the services are being provided or not, whether all the diagnostic services are the logistics, the equipment, the consumables are available or not to provide the quality care, whether the HR, the primary healthcare team, service providers are skilled enough or not, whether the accessories, like as on today, if you have to report, if you have to have a key, if you have to have the fully fledged SWC, the internet and the power and uninterrupted power supply, the water facility, the water connection, and also for example, in a PHC, we need to have a separate set of toilet for male and female. So as per the existing norms, IPHS norms and CPHC norms, we have developed this structured checklist, and the team members visit these facilities very regularly and then understand whether the mandated services are being provided or not. The MQA data is it's a mentoring and quality assurance visits which we carry out at the IGNU notified study centers, where we interact with the faculty, the academic counselors, and also the candidates, the students who are undergoing this certificate course. We try and do the knowledge assessment twice in the course period to understand whether the knowledge gain and the is as per the norm or not. And also we try and do the practical, the clinical site visit, and then understand whether they are learning all the clinical parameters, all the clinical skills they are mandated to learn in the certificate course. And we do track all the CHOs right from the beginning, right from the admission into study center and to the towards the exit from the study center. Sort of line listing we have maintained so that their performance, whether they have passed the studies, that they have completed the certificate course, and whether they need to undergo any additional courses, additional training programs. We have established that mechanism so that the HR coming out of the CHOs coming out of the certificate course are confident and competent. So for this purpose, we do have a in-house team who have expertise in the digital platform and also the big data analytics. With the help of the in-house team, we have developed dashboards which sort of guide us in understanding what has been the progress, what is the trend, and also the key. For example, there is a element called incentive dispersal for the primary healthcare team. We have worked with the state governments to develop a dashboard, sort of to develop a digital tool to track, to simplify the incentive dispersal, and to understand which are the facilities, which are the districts, which are the healthcare providers who are receiving the incentives, and what are the if they are not received, if they are not received, what is the reason, and we try and address at the appropriate level based on the findings, based on the understanding from the dashboards. There are few along with regular the data collection through supportive supervision visits and the MQ visits. We do have the evaluations to guide the program on the right track, whether we are on the right track to achieve the intended outcomes or not. These are the few examples, few studies which we have designed in-house, and then we have partnered. We are working with state and the national ethical bodies, IRB centers, so that these are implemented on time, and we understand what has been the progress and what need to be done if we need to correct if we need to improve our progress. These are again the few indicators which we have designed. The COVID disrupted most of our activities. Because the same health system, the primary healthcare system, was forced to leave. I would say leave the non-COVID essential activities like immunization, the care for mother and child, or the treatment for TB or the NCD patients, and they were forced to cater to the COVID patients. So we were forced, and then we were given that opportunity to design few interventions against the COVID, keeping the primary healthcare team in mind. And based on the interventions, we had within short period of time we had developed this M&D framework to guide our primary healthcare team's response to the COVID. And also the few other interventions in the area of the oxygen system and the wash, and with the large amount of data flowing through these interventions, regular data that is being flown, we have developed our learning agenda, and we have partnered with a few academic institutions so that we are able to produce a generalizable and a sort of robust evidence. And what we are trying to do with these findings is that with the COVID residing, all our efforts, all our responses in the COVID are being diverted to make the health system resilient, because we all understand India is a fertile country for next any epidemic, because of our socio-cultural, because of our the demographic factors, and then because of many other parameters. The disaster can happen in similar epidemic can happen anytime. The only way we can prevent the human loss is making the health system resilient, so that it bounces back, and then it gives the required response to the population it's being carried. Again, in the area of COVID also, we worked with the local partners, and also especially the tech partners, to strengthen the COVID response, especially in the area of home-based care, because especially during the second and third wave, it was observed that more than 70% of the cases can be managed at the home level. A basic support through a counselor or through a telemedicine services was sufficient to ensure that we did develop status dashboards on the right from the patient movement. When the COVID person is any person is diagnosed with COVID, we would receive the information from the state M&D cell, and the dashboard which we have developed at the state level. For example, in the state of Mizoram, with the dashboard, the state leadership were able to understand how many patients are under home isolation, and with the system we have developed with the partner, the teletrack, we were able to identify. We were able to implement the triaging. Any COVID patient who identifies any who develops any alarming symptoms like or on the verge of complication, we would identify. The state leadership would get the alert, and the nearby facility would in turn be notified, so that proper care is mobilized towards that patient. So we use these dashboards, we use the digital technology during the time of the peak COVID second and third wave to help the state in giving care closer to their homes.
moving ahead.
Again, in the area of COVID and the service, there is additional component for the data source. There is something called IHIP portal. Earlier it was called IDSP, Integrated Disease Surveillance Program. Now it has been transitioned into IHIP, where the right from the ANM or the subcenter to the tertiary facilities, they use this platform to report the disease-related numbers. So we are working closely with these 8 states based on the numbers that are being reported in the IHIP portal. We are mobilizing the resources. So, for example, in the state of Maharashtra, we work with the IHIP cell, IDSP cell, we would say, and to understand the pattern of diseases that are being reported in the past 5 years, and we were able to identify few outbreaks that would have been otherwise missed through the dashboards we have developed in the state of Maharashtra. So again, under the IHIP the surveillance project, we have been able to design few studies, the evaluation programs, to understand what has been the progress, what can be done to improve the overall IHIP system, and the huge amount of numbers that are being reported, maybe because of many reasons that are not being utilized or that are not being put into action. So we are working closely with the state IDSP cell and also at the NCDC level, so that these numbers are put into action, and then in the future the epidemics or outbreaks are identified at the early stage. So I have tried to summarize with what we do and how we collect the data and what we do with that data. There are few system-owned portals like SWC portal, NCD portal, or the HMIS or the RCH portal, and also we have developed our own mechanism, our own dashboard, our own data flow mechanism to have that robust source of data, where we during in the area of our technical assistance, we use this data mainly at the state and national level to drive the program review mechanism or the regular feedback mechanism. For example, from the SWC portal, we are able to we have the option to understand how many patients are being how many persons are the footfall at the health and wellness centers. And we could see during the COVID, the lockdown, it was logical, the number of patients have come down. And that is when, though COVID has receded, we identified there are few facilities which are not, which had not picked up the footfall in terms of patients coming to the facilities. Then we identified that because the CHO has been deputed to a higher facility, and then the CHO has not been brought back to that subcenter. So still the outdoor is the outfall, the footfall or the OPD numbers are very low. So these are small examples, but we were able to identify in time and then help the state governments to take appropriate action. And as I mentioned in the beginning, there is a system called incentives for the primary healthcare providers. And this is just to motivate the CHO ANM to remain in the field to deliver all the mandated services. But if the incentives are not paid to them, the whole purpose is lost, and then they'll not be able to give that intended services. So we have developed a tool right from the calculation to dispersal of incentives in the state of Maharashtra. With this tool, the state nodal officer or the state leadership, they immediately get notified on those districts, on those facilities which have not been able to disperse the incentives in the past few months. So the data was already there. There is that with the expansion of HR at the primary healthcare facilities, especially the CHO, and with the expansion of digital platforms, especially the internet across all villages and panchayat, for example, the BharatNet. So we have been able to leverage the technology revolutions and put data into right use and help the healthcare providers and also the beneficiaries in receiving the quality services. Briefly about challenges. Yeah, COVID-19. We can continue speaking on COVID-19. What challenges it posed across all levels. The MND plan was completely put aside because there was lockdown, and then we were not able to move, and data collection plans were completely stopped across all the evaluation studies which we had planned. But we did use technology in some places, like we carried out telephonic interviews. We carried the in-depth interviews. We used Zoom and other platforms, and we were able to make up some time that were lost due to COVID lockdown and restriction of movements. And shift in focus due to COVID, it was obvious, it was natural. The non-COVID essential, the non-COVID services became very secondary, and none of the health system functionaries were ready to start working on the anything that is beyond COVID. So we did receive the drawback in terms of our planned activities, and because we work across 12 to 14 states through different support, USAID and BMGF support, there is difference in the data quality, data completeness, the timeliness, and also the heterogeneity. Because we understand each state. For example, in northeastern states are well literate states, and the digital literacy is also quite good. But so we can expect the reports coming out of northeastern states are quite complete and timely. But there are few states in the EAG group of states. The digital literacy is not so good, and then the quality of the information that we receive is not up to the mark, and then we can't draw conclusions. We can't compare between the state level information. That is another challenge we face. And because of the health is a state matter, there are the policies sometimes matter on the data reporting and sharing mechanisms. And another challenges which we are facing is the CPHC is a very evolving subject. When we started our interventions in 2 years back, we did not know what is wellness in the health and wellness centers. What are the wellness activities? It was only yoga as defined. Yoga was defined as the wellness activities, but now the concept has evolved. There are many array of activities which are defined as wellness activities. So to fit our MND framework with the evolving nature of the evolving concept of the CPHC is another challenge which we face. And there are few interventions. If you have followed recently, there is something called PM Abhin, Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, and PMJ was already there. There is another Ayushman Bharat Digital Mission, which these are few examples which they have direct impact on the what is being provided in the primary healthcare, comprehensive primary healthcare context, and making the relevant changes in the MND framework to capture these key interventions. So if you are going to state and the national level, the leadership, the first question they ask is, how is the recently launched PM Abhim, how is the recently launched ABDM program being taken up, being implemented across the primary healthcare facilities. So to make those changes as per the evolving nature, as per the new interventions that are being implemented, that are being initiated in the area of comprehensive primary healthcare is something we perceive as a challenge. And we all understand quality comes at a cost, and if we want a good quality product, not just in the market, but also in the service sector also. We will need more resources, not just the funds, but also the time and the HR. So we do work in the resource constraint areas, and then we try and manage. And COVID also has created the crunch of resources. So these are the few challenges which we could list out. This is our team. We have a strong team, dedicated team. Comparatively, as per my experience, this is one of the biggest team within the Jhpiego also for the CPHC. Diverse team, I would say, not just medicos, non-medico. Even we have few engineering background people who are helping us in the M&D programs. So I'm happy and proud to say that with this robust team, we have been able to establish a strong M&D structure for the CPHC activity we are supporting in these states. Thank you.
Thank you so much. So you can take your seat. Some questions will come. You can sit here and
We can sit.
answer also. Thank you so much, sir, for all your insights. And I think this is the time when we can have a few questions from our participants here. I think we have time for about 1 or 2 questions. Please, over to you. Any questions from anyone? Till then, think of a question. Let me share some questions which have come from our online participants. So there's one question, sir. What is the importance of evaluating the sustainability component of a program?
See, I'll be very cautious in defining that sustainability component. I'll take an example of mobile HWC. Like in any state, we work with the state and another partner, and we developed a small van, school van, which was redundant, and we sort of repaired, and then the resources were quite amount of resources we had to spend. That goes to a far off village, tribal village, and then the footfall is around 10 patients per day. So I can't compare that 10 patients with the 10 patients that are coming to the facility. So yeah, I agree. There we have spent so much of resources, but looking at health is something which is not very tangible. So I'll be very cautious in defining all the health interventions in the lens of sustainability. So and COVID has derailed everything, and then again it keeps on changing. I don't know if it addresses.
Thank you, sir. I also have a question. So I believe that the NISHTHA program has been involved in building the capacity of the community health officers, the health and wellness center functionaries on the expanded services. So including mental health, etc. So are there any insights around how monitoring and evaluation is helping to strengthen this capacity building of CHOs on the expanded services?
Yeah, there are few activities which we have, which are part of all the capacity building activities under NISHTHA. Like bringing the right person to the training table. Usually what happens is that a training is being planned, the medical officer, this person is very close to me, this person is useless for me, send that person for the training. So we wherever possible, we try and see that the selection criteria for the training participants are set in the communication that is sent to the facilities. And we have a sort of quality assurance checklist for each and every training, right from the preparatory activities to the post. That includes infrastructure and accommodation facilities also, so that the person who is coming for the training has the conducive environment to learn. And another integral part of all the capacity building activities is the pre-test and post-test. So we do assess the pre-test and post-test scores and then see what has been the progress. And another example we take is the any skill-based training. We have a structured checklist. Like we have a package called Saksham package. We have identified close to 95 skills for the expanded range of services. Whenever that person comes for that training, we try and use that checklist. We try and give that checklist to all the participants so that they don't miss out on any key steps in a skill. For example, EMTSL, management of that stage of labor. There are key steps that are defined. These are the 3 main steps that need to be done to complete this skill. So we have the checklist. We share the checklist with the participants and then ensure that all the steps are followed. Another important component is the post-training follow-up. So you give me the training and then I am happy 3 days in a AC all. I am very happy. I meet people and then I go back and then I forget. So we try and avoid that by ensuring the visit to that facility, whoever is getting trained, and try and help them inculcate this skill at the facility. So the SSV checklist which I was referring, the supportive supervision checklist, does contain the skill component, and they when I go for the SSV supportive supervision visit, I try and see what skills that are being provided, the skills that are being used by the trained person in the facility.
Great, sir. Thank you so much. That actually is an area I personally am very interested in. So your answer was very informative. Thank you so much. Yes, this is another chance for our participants here to ask any questions on related to the insights shared by Dr. Ravi Kumar on monitoring and evaluation. Any questions from you?
Yes.
Yes, please.
So, sir, based on your presentation and that knowing that you know the current status of medical infrastructure we have. So, suppose God forbid it doesn't happen, but another pandemic epidemic comes in a year or two. What is our capacity to handle it? Because we have seen what COVID has done to our.
See, infrastructure is something which takes not just the large amount of resources, money, and also large amount of time, especially in our political system. Like to get the bid issued for that infrastructure, it takes 3 months, and then tender finalization another 3 months, and then the contractor who comes. Let's not get into the governance part. So infrastructure is something which is not under everyone's control. Saying that, for example, in the recent initiative is called ECRP, ECRP2, that is specially designed to respond to the COVID-like pandemics. There has been a concept of prefabricated structures. Like it's not that each and every PHC. I'll take the example of PHC, primary health center, which are usually 5 to 6 primary health center in each and every block. Not each and every PHC is mandated to give that COVID care. So if in a block there are 5 PHCs, if you are able to identify one PHC as the COVID specific, not just COVID, any infectious disease epidemic specific center, and establish that prefabricated structure in that facility, you have space, and you can get the electricity and internet connection done. And then if there are no resources, these prefabricated structures even have the facility of teleconsultation. So as a plan, it's very ambitious. It's there in the paper, and few states have gone ahead, and we do have adopted our SSG checklist to monitor these prefabricated structures also. But as I said in the beginning, it takes time, and then it requires a lot amount of advocacy and feedback at many levels. Infrastructure is something, yes, that we are also, everyone is facing the issue.
Thank you, sir. I think there was one more person with you.
Basically, sir, the organization or the initiative of your health like intervention in the comprehensive primary health care. So I've seen in your previous slide, so working in two different regions of India, like one are the states where your interventions in Bihar, Jharkhand, Chhattisgarh, this bad, and another set of interventions that you're leading is in the very
Northeast.
far northeastern region. So my question is, what are the key challenges that you're facing in two different settings?
Yes.
In respect to comprehensive primary health care, and the related question to this is another part of the question is how you are looking the role of AAAs, basically ASHA, ANM and Anganwadi, like the frontline workers in the whole setting, like enhancing the healthcare services and the model that you have explained. So how do you see their services in the existing framework?
Their role in the existing framework. Yes. For the first question, yes, there are good and bad. I'll focus on the good part. For example, in the northeastern part, the community part is quite strong. Like there is an example in Nagaland, there is an example of community kitchen. We were working with few facilities. There are no institutional delivery facilities in the local area. We work with the local health leadership, and then the delivery services were initiated. If someone is going for a delivery in institutional delivery, the person is mandated to stay for at least 48 hours. And one of the biggest problem is the comfort and convenience of the person staying in the facility for 48 hours. If I don't get warm or a comfortable weather in the facility, that AC or the warm during the winter, and if I don't get home cooked food, I'll not stay in the facility, I'll go off. So the facilities which I'm referring to, the community over there, they started developing with their own resources. They developed a community kitchen in that facility, and whoever stays in the facility, they started giving food, community cooked food, which is accepted by everyone. So, and literacy is good in terms of the education, and so that gets converted into good data, quality data, timely data, and complete data. And again, if I don't record something that doesn't exist and that did not happen, and I'm not able to review the progress, so good amount of data is coming up. The disadvantage in these areas is the infrastructure, especially the ICT, information communication and technology part. That the penetration of internet is very poor, and even the digital literacy is quite poor. But there are few mechanisms in the system, the NHM and the because system is providing system is providing the smartphones and tablets. So the system has partnered with the BharatNet. There is a scheme called BharatNet, which is being tried, where they are trying to establish internet connection across all panchayat, at least till panchayat level. So there are, in terms of infrastructure, the challenges are there, and also the because of the hard to reach areas, hilly and other areas, the review mechanism is not very penetrated. Even for example, if there is some review body from the government of India, they can easily go to a part in Maharashtra or a Chhattisgarh or Madhya Pradesh, but to reach a part in Arunachal Pradesh, similar part in Arunachal Pradesh, they would for one day work, someone has to travel for 5 days, 2 + 2 + 1 day work. So infrastructure, travel, and this part, I would say, is still yet difficult. And when it comes to AAA, yes, ASHA are the basic functionary for the healthcare system, because there are many activities, especially the CPH in the CPHC context, like I would say population empanelment and population empanelment. So ASHA has to undertake that activity exercise in our area to include all the people in the facility. If there is a village, and that village has to be mapped with the nearby facility so that no person is left out, and that important activity is on ASHA. There is something called CBAC, Community Based Assessment Checklist, where ASHA has to make house-to-house visit and do the sort of first level of screening, first level of identification for identifying the high-risk people in terms of NCDs. So even if you look at that CPHC operational guidelines, they have beautifully explained the service delivery framework, like which cadre of person, which cadre of health worker, ASHA, ANM, CHO, and above, what type of activity they will provide. As a ASHA, my job is to ensure treatment compliance, regular follow-up, health education, counseling, that type of activities, community level activities. As a CHO, my job is to do that regular screening, regular checkup, and help the ASHA and ANM in the community so that all healthcare services are connected. ASHA, as we say, she is the bridge between the community and the healthcare facility, and through health and wellness centers, we're trying to strengthen that bridge. Does that answer your question?
Yes, very much. Thank you for that.
And one last. Dr. Ravi, I would like to understand what are the monitoring mechanism and what levels we follow in terms of monitoring
For
the larger projects, what you have, especially for this time. What different levels you have for monitoring? What
For
is the
the-
monitoring mechanism? My question is different from this question. I would like to understand the monitoring mechanism which you follow. Basically, what are the different levels
within the project.
within the project?
Yes. So as I shown in the last slide, our organogram, M&D organogram, we have a basic person called data analyst. He is equal to almost data entry operator. The person just collects data and then just feeds into the system from all the program people. The program people, I am a program person who goes to facility, who goes to community to collect that, to fill that checklist, and then the data person, that the data analyst, yeah, data coordinator, they feed into the system, and then we have that regular review mechanism. We don't review actually. We have that data. That sort of mentoring mechanism. Regular meetings with the state team on the data they have produced, and then the findings which we extract from that information they have provided, like SWC portal or the SSV, the supportive supervision vision checklist. So right from how many supportive supervision visits that have happened, like for each and every state, we have said, for each and every staff team member, we have said at least 3 facilities need to be visited in a week. So if you have some 10 people, 30 facilities in a month for that state. So we have set up for each and every intervention, we have set up key indicators which I showed in this slide. So key indicator, and then we have defined the frequency also. When does that? There are few indicators which we ask the team members to share that fortnightly, and there are few indicators monthly also within NISHTHA, and also with the donor and also with the stakeholders, other stakeholders. So the data we produce are put into use at the state level and the district levels. Whenever I go for facility visit, I make a brief report and then share it with the district official and also with the state official. So with the state officials, state leadership, once in a month, we give a crisp feedback, what has been the observation, what support we were able to mobilize, and what support we require from the state and district leadership. So for each and every activity, sort of we have converted that into a indicator. And for example, number of facilities that we are visiting, or number of trainings we have conducted, number of MQA visit, like number of CHOs that were given the knowledge assessment test, and then the first and second knowledge assessment test. So for each and every activity, we have defined indicators that M&D framework, MEL framework, right? So frequency, what type of data, and who will use the data, and how it is being used, and to what level. And one more part is that sort of that the findings we share is not same for all the people. For a block medical officer and the district civil surgeon or the CMHO and the state leadership, the findings are totally different. So a person at the block level would like to know what skill, how many Ashas are there, how many Ashas are trained, how many Ashas are not trained. For a state leaderships, a larger picture like infrastructure, the deficit in the HR, the HR rationalization, that type of information. So we try and stratify the data for each level, and that is what we have been taught, and that is what we have been discussing.
Can we take one or two more questions? Is there time for that? Okay. Sure. Then I would request Professor Arun Karpo, who is chairing this session, to make his comments.
Thank you.
Go. That was fantastic. Thank you, Dr. Ravi Kumar, for sharing your work and the work of your organization. I really congratulate you on all the efforts that you made in place, especially during these difficult times for COVID-19, trying to take care of hard-to-reach areas and taking care of moms and kids in our country. It's a fantastic effort. I am so pleased that you spoke about theory of change. You spoke about logic model. You spoke about measurable indicators. These are some of the concepts I've been hammering the entire group here for last 3.5 days and one more day to go. So guys, this is not a pure academic exercise. This is real, and you can see how agencies like Jhpiego have been able to implement it, use it, leverage it to their benefit. I'm so impressed by their ability to organize the data, synthesize it, as well as visualize the data and make sure that learnings from data are informing their quality improvement practices within the institution. I think their ability to partner and equip the government machinery that is trying to provide care is laudable. And so I thank you for taking time today. And I'm more pleased to have met my fellow physician who also chose the path of public health, and he also happens to be from Karnataka, shares my language. So thank you so much. It is always a pleasure and a joy. And thank you all for staying up and being part of the conversation. I also wanted to especially thank those viewers who have joined online for us. Thank you so much for joining today. And I'm so glad that we had such a wonderful conversation. Thanks again. Thanks, everybody.
My sincere thanks again to Dr. Ravi Kumar for this very insightful talk. I will now request my colleagues, please take the felicitation of our dignitaries here today. I would also request my colleague, Dr. Swami, to felicitate.
We'll felicitate him tomorrow.
Okay, all right.
Thank you, everyone.